Good afternoon. My name is Geoff Gallop, and I'm representing the Global Commission on Drug Policy here at HR23. I'd like to begin by acknowledging the traditional custodians of the land on which we're meeting. We pay our respects to the Boon Wurrung and Wurundjeri Wurrung people of the Kulin Nation. We pay our respects to the elders across this land and their never-ending push for change. We recognise and pay respect to the future elders and their advocacy for equality. We acknowledge the connection that exists between Aboriginal and/or Torres Strait Islander people that they have to their lands, waterways and skies. We're gathered today to discuss drug policy reform, its advocacy around the world. And I'm very pleased to say that we have 5 wonderful speakers that will bring their own perspectives to that subject. One of our speakers unfortunately couldn't make it, so each of our speakers that are going to be with you have got 12 minutes each to speak, and then at the end of their presentations we'll have a question time. It strikes me that there is a theme, I think, in the 5 speeches that we're going to get, and that is that public policy is never really public policy unless it involves the advocacy and the processes by which people get involved in and support drug law reform generally. It's, one thing to have a good idea based upon evidence about how we should do things. It's one thing to do and another thing to have a good plan to implement the policy that you have. The hardest bit, in many ways, is to get support for it. And I don't mean just here the general support in the community, but I know we will be discussing that as part of the presentations today. And I don't necessarily mean either just the stakeholder support that you need to be able to carry out reform. I'm also talking about the ownership that's needed for some types of reform. The very essence of some reform is to engage people and involve them in the process. So I think I hope there will be that theme that we can't really have policy until not only the idea is well developed and relevant and evidence-based, but also that it can be implemented, and most importantly, that it's properly supported where it needs to be supported in order to make a difference. So with those preliminary comments, I hope that they help in terms of understanding why we have this panel here today. I'd like each of the speakers to restrict themselves to the 12 minutes. I'll bang on the water bottle there when your time's nearly up so that you've got some idea, and then we'll have the question time. Now, my first speaker today is Machteld Busz, who's going to talk on the XTC shop, using art to foster dialogue and investigate public acceptance of substance regulation. Machteld is from Mainland, many of you would know, based in Amsterdam. Thank you very much, Machteld.
Thank you, Geoff, and hello, everybody. Good afternoon. Indeed, my name is Meg Busz. I am the Executive Director at Mainline Foundation, but I'm also one of the initiators of Poppy, Drug Museum. And just very briefly, because I don't have a lot of time, Poppy is a social enterprise that was established by Mainline in 2019. And different to Mainline, we focus with Poppy on the general audience, general public. Mainline is very much a harm reduction organization. We work with marginalized people who use drugs. But over the years, we found that there's a missing link, and that's the general public, who is also very misinformed about drugs. They need to learn more. And also, we were looking for new opportunities to fund our work. So Poppy is a museum about drugs in sort of establishment. We are building it gradually by organizing pop-up expositions, and hopefully we can open a first location by the end of the year where we have a fixed site and actually start generating some money for the movement in the end, but also, of course, to educate the public about drugs. So we're doing different pop-up expositions on different topics around drugs. And the one I'm talking about today is our ecstasy shop. Just a very brief background about MDMA ecstasy in the Netherlands. We are one of the key producers of ecstasy, and I think if you take pills here in Australia, there's a high likelihood that they originate in our little country in Europe. So that's a problem, of course. There's a lot of associated crime with that in the country. There's a lot of environmental damage in the country. At the same time, it's a very popular drug. So we have over 1 million ever users of ecstasy out of a population of 18 million, and around 150,000 users in the preceding month. It's a drug with a relatively, comparatively low risk profile, so it's an interesting drug. And of course, there's a lot of developments around it in a therapeutical setting and its medical use, especially for people who have severe traumas. So a lot is moving in that space, and it's a topic that is sort of there's a hot debate about ecstasy in our country, and very polarized, in particular when it comes to people who use it recreationally, which is a lot of people, with our conservative politicians, of course, pinpointing them down for being responsible for this waste, for example, or for the crime that is related to ecstasy production in the country. Now, we read a lot about drugs, and we were extremely inspired by especially this book, How to Regulate Stimulants, a production of Transformed Drug Policy in the UK. I haven't seen them around, by the way, but I think they're fantastic. And this book brings a lot of detail on if you would regulate MDMA, how could you do that? And I find that really interesting because, like I said, the debate in the Netherlands is very polarized, so it's usually, components and opponents just shouting to each other, saying, yes, regulate, legalize, no, we should be more conservative, repress the whole thing. And with this publication, we were very inspired because it speaks beyond that discussion and says, okay, let's move beyond that yes or no discussion and look at how would it be possible if we decide to do that. And I find that really inspiring. And that led us to organize this little shop. We rented a place in Utrecht, which is a city in the Netherlands, and we basically dressed it up as a shop where you can buy ecstasy. So this was actually a really busy city area. You see here in Dutch, it says, come in, feel good instantly, let's get high, stuff like that. So of course, also sort of trying to entice a bit with art, the general public, like what would you find acceptable if we would sell ecstasy legally? Would you want this to be part of your shopping street? Well, probably not, because this is of course a lot of marketing. But of course, when you use art, you can be a bit more bold and, also mess with people's head a little bit. So this was the outside. We built an ecstasy shop together with artists, and it was sort of a social sculpture. So we created a world where you basically enter as if you are entering a shop where you can buy legalized ecstasy. Now, just as a disclaimer, we didn't actually sell ecstasy because then we would probably be closed down immediately, but it was a social experiment. And we used 3 different settings. And this is all based on that publication that I showed earlier. So, of course, when you regulate, there's lots of choices that you can make. And we figured, okay, in the Dutch context, you could have 3 models. For example, in a club setting or a festival, this is just a vending machine, get your pills out. Sort of a smart shop setting, that's a bit Dutch, but we have that in the Netherlands, where you can buy all sorts of legal highs, or a pharmacy setting. And so we had in that shop these 3 sets rebuilt, and people could enter it, and we invited people over, just general public. They could visit this shop for 2.5 months, and just engage, be in that shop, sort of imagine what it would be like, and in each of the sets they would answer lots of questions. So it was also a part of a sort of a research that we did on site. Now, super nice in terms of advocacy. We also invited, in addition to the general public, a lot of politicians there, local politicians, but this here, without hair, the bald man is our Minister of Health. And it was really exceptional with a bit of a weird initiative like this to have the minister actually come over. He's interested in this topic because it's such a hot debate. And he actually spent a lot of time in the shop talking about, okay, if we would do it then how? And that was really the first time in my 10 years career in the drug field that we had a serious, open conversation about how can you regulate a substance like MDMA. Well, you can imagine it attracted a bit of media attention as well, and the topic today is, of course, advocacy. Well, we managed to get into the newspapers, on TV, on the radio, podcasts. We even made it to The Guardian, which is for us, whoa, cool. The Guardian is writing about us, and actually all the articles were very much, particularly what we wanted, about the question, how could we do this? So I think we really made an impact in that sense in moving the debate away from the yes-no discussion into more of a, let's have a serious conversation about this. And like I said, this was also a research setting. So in each of the sets, we had like 12, 13 questions that every visitor could answer. And in the sets that was slightly different, in the Smart Shop, for example, we asked a lot of questions around marketing. Would it be allowed? How many pills would you be able to buy? Can I buy for my friends? Can I advertise? Can I also put it in all sorts of fun things like lollies and drinks and stuff like that? Or should it just be prepackaged pills? In the pharmacy, it was, of course, a bit more high threshold, let's say. So we would ask questions like, would you be willing to hand over your medical file? Would you be willing to, ask a doctor prescriptions? Questions like that. And in a club setting, we would also inquire about what would you do then if you could buy that in a club? How would you handle alcohol, for example? Would you be willing to take a breathalyzer test if that would allow you to get an MDMA pill? How do you handle other drugs? Are you zero tolerant on that, or would you sort of condone that? And all these questions are now just recently published in a research report. You can scan it if you like. It's in Dutch. For the person who has €1,000 for translation into English, you get a free tote bag. And then I can arrange that for you, because I think it's actually worth it. With citizen science, it was a public experiment, so there's a lot of, for the academics among you, really a lot of disclaimers into, the quality of the data, but it did give a really good insight of the public acceptance of this. It gave a really good insight in how people are very capable of thinking about a complex topic like this, and that people are really taking responsibility about this topic, in the sense that, in our country, people are sort of put away as these hedonists that don't care, they just want to have their own pleasure. But in fact, in the shop, people were really thinking, okay, for me, maybe the club setting would be fine, but what about vulnerable people? How can we protect them? What sort of information should we give them? And in the end, people came sort of to consensus about a middle model, somewhere between pharmacy, which is a bit too high threshold, and the Smart Shop, which is a bit too marketing-like. So they came to sort of let's say a neutral shop where you would be able to buy this. And I mean, the people that came to the shop, of course, had an interest already in the topic, so it's not representative. But the common message was that they would really be in favor of regulating this better, with the argument that it gives you way more control over this market. So that's our story about the ecstasy shop. I think I'm on time. Yeah. Great. So our next steps with this, the report is just out 1 week ago. We published it. And of course, we're going to target again all these politicians. There is a state commission now that is discussing the medical introduction of MDMA in the Netherlands. And we figure, okay, let's push them to also talk about recreational use. So that's next step. Also on local level, there's lots of opportunities to talk about with politicians about this. And we really want to also find ways to get this shop to other cities. So that's something that we would like to look into, other cities in the Netherlands, but maybe also abroad. We had some interest from Ghent, from Manchester, and I think it's a nice way to see also the international differences and responses to this. And of course, Poppy, if you'd like to know more about our museum, come talk to me. We hope to open a permanent location, and then this will be part of the collection, of course. So that's our story. These are some Poppy contact details. Why is the clicker now stopping? Well, anyway, find us at poppy.nl. Yeah, there you go.
Thank you very much. And I was struck by Machteld mentioning we're moving from the pro or con of regulation to the how it could work. And I think that's an important shift that has to be made. And it's great to see a project where the people are being involved in seeking an answer to that question, because the legitimacy of the particular model that comes up is just as, if not more important than the general idea that lies behind that particular initiative. So thank you very much, and all the best with the program. Our next speaker is Alison Ritter on participation and engagement in drug policy. Alison, of course, from the University of Professor at the University of New South Wales here in Australia. Thank you very much. Alison.
Thank you very much. Can I acknowledge the traditional owners of the land on which we're meeting here today, the Wurundjeri people of the Eastern Kulin Nation. We're not paying rent and we need to. They have been wonderful custodians of the land. Thank you so much for coming along to hear about participation and engagement in drug law reform. A lot has been written about the theories and practices of participation. Summits, citizens' juries, ways in which we participate as formal members of committees, and a variety of other things. All of these sort of formal participatory mechanisms characterise participation in a kind of an event-based or an action-based or sort of formal way. And there's been some strong critique of participation in these formal settings because it constrains or constricts participation to conform to the expectations of those who are in power and those who create these places of participation. This work that we've been doing asks, are there other forms of participation? And can I acknowledge my co-authors, Kari Lancaster, Laura McLaughlin, and Matt Kearns in this work. So we're interested in other forms of participation. What we aimed to do was to study participation in the wild. How does it actually happen and occur? And we did a series of case studies. We actually did 4 case studies, but because of the limited time, I'm just going to talk about 2 of them. The first was participation in a campaign to change the drug laws in New South Wales and the ACT. The methods there were ethnography, with participant observation over a 13-month period, supplemented with semi-structured interviews. The second case study was around COVID and the changes to the opioid agonist treatment that occurred. We wanted to study the way in which participation occurred at the time of those policy changes to opioid agonist treatment, and that was semi-structured interviews. Time is too short. There are hundreds of insights that we've gained from this work. Today, I'm going to focus on 3 key findings, and I'm drawing on 2 of our papers from this work, the first by Richard Mellor and the team, and the second by Laura McLaughlin and the team, and just email me if you want copies of those 2 papers. So the first finding is that participation happens in diverse ways and diverse settings. So yes, we observed the usual settings, formal meetings, roundtables, workshops, committees, submissions to inquiries, but we also observed less usual settings. In a particular COVID-related era, there were these long Zoom calls going throughout the night, particularly amongst drug user organisations. We also observed participation at celebrations and at parties, at a launch of art. So my preceding speaker was a perfect foil for this expansive notion of participation that I'm trying to encourage. We ran a drug policy trivia night, which was an enormous amount of fun, but another form of participation. We saw participation in marches and protests. We saw, there's the art, the launch of an art exhibition. And it happened in churches and in community halls, on the streets, in non-government offices. And indeed, it's these other settings that were much more common. So these are settings that aren't in a government-owned building, in a meeting room with PowerPoint, pads of paper, and mints in a bowl. So participation in the wild is very rich and very, very diverse. The second of the three findings I wanted to talk about is that past practices of participation presage new practices. So we're all very familiar with the formal tables of participations. And for drug user organisations, these have been hard fought and are now almost institutionally mandated that every committee must have a drug user organisation representative on it. And you can see the quotes here from the case studies. We as a sector have worked really hard to make sure that the drug user organisation is at the table and a respected voice at the table. And I love this quote: participation is about having a seat at the table. The facts of the matter are, if you are not at the table, you are on the menu. And we know how these tables, these formal tables of participation work. Governments use formal committees to reach consensus, and then they make a decision out of session. Basically, everyone gets this to say their piece, and then I guess the government goes away and thinks about it, and then the person laughs. So what was interesting about studying participation during COVID was that the committees stopped meeting. So we were operating under these kind of emergency conditions, and these usual tables were not present. So what happened? What happened was a new form of participation emerged, and we characterised these in our analysis as huddles. These huddles were very different from tables. So tables, you have a fixed agenda, you almost already know what the action items will be before the meeting even starts. These huddles, by contrast, comprised of the membership of the tables, were brainstorming and problem-solving spaces. They were troubleshooting forums. They recognised uncertainty in a way that the formal tables do not. They were also where solutions to tricky problems were made, this quote. The huddle, for example, was where we worked through the policy issues for amending takeaway doses. That's carries for our North Americans. So we observed this new form of participation which provided new affordances and new opportunities. But perhaps most importantly, it needed the tables to have been there before. And this quote, I guess because of the formal committee, we did have that established network of local stakeholders whom we could quickly and easily draw upon and convene to start working through these issues. So thinking about our current formal forms of participation, they are really important to enable and facilitate the emergence of these new and very productive, in this case, forms. And the third finding I want to talk about is disagreement and difference. Most formal forms of participation are about agreement and consensus. Everyone in the meeting has to sign off on the agreed actions. Everyone in the a citizen's jury has to reach consensus. And we know from an advocacy point of view, it's very important we have agreed strategies and we speak with one voice. However, this means we ignore or avoid disagreement and difference, and that, I argue, is at our peril. When we studied participation in the wild, we not only recognised significant conflict and difference, but what we saw was it being embraced for its productive potential. So in the case studies, there was lots of space for disagreement, there was anger, there was frustration, there was not physical fisticuffs, as the person says, but, people stood up, spoke their piece and walked out of whatever the particular form was. But when we spoke with people, they really valued that. They valued the disagreement and the ability to disagree well. What we also observed was the labour associated with disagreement. It's very hard to stay present in disagreement. You need to resist the urge for consensus or resist the urge to disengage. But staying present in disagreement and in difference is so important because we are not the same. And in fact, to try and achieve consensus, to think with a theme of the conference, is to colonise. We actually want difference and disagreement. That is decolonising. When we stay present with difference, we recognise and respect the different obligations that each member brings to both formal and informal settings of participation. We also have labour of maintaining connection across difference, and that labour is quite hard. It involves processing hurts, repairing connections after disagreement, and supporting others to do likewise. In our analysis, that labour was often invisible and it was very unevenly distributed. So some people engaged in a lot of that labour and other people did not engage in that labour at all. So to conclude, I think we need to think much more broadly about participation. We need to go to the ecstasy shop, we need to go to informal settings, we need to think about participation being all of the things that we do when we come together to talk about, for example, drug law reform. If we think about each occasion of connection, whatever that might be, as a form of participation, it means we will think about power and we will think about process. And they're the important things to think about when we're talking about participation. As I hopefully shown through the data, emergence can arise even from the most foreclosed and institutionally mandated participatory structures. And here I think about things like the CND, the Commission on Narcotic Drugs, and other formal forms of participation. How do we expand those out to emerge new forms of participation for more productive drug policy reform? And in that context, how do we stay open and adaptive to these new productive forms without needing the emergency of COVID, which is what forced the huddles? And lastly, I think we need to encourage difference and conflict. We need to embrace the fact that we are not going to have the same views. We are not going to share the same positions. That is not a weakness. That is actually a strength. And it's a decolonising move. Whilst we embrace disagreement and embrace difference, we also need to recognise the labours that go along with that process. Thank you very much.
Thank you. Thank you very much. Tables and huddles, there's lovely imagery that relates to both of those, and it's good to be reminded sometimes that the formal processes that we have do make certain assumptions about what matters and what doesn't matter, what should be listened to, what shouldn't be listened to, and we can forget the underlying conflicts that may be there all the time. So thank you very much, Alison, for that. As a person who promotes a formal process of citizens' juries and assemblies as I do, it's nice to be reminded that the world's a bit messier even from that. Our next speaker is from Norway, Torre Rimo, and it's on a particular project, a Norwegian heroin-assisted treatment project, and the relationship between the patient and the nurse. So I'd ask Torre to come forward. Thank you.
I just discovered that I have 12 minutes instead of 7, 30 minutes ago, so I will use whatever time I use. I would like to acknowledge the traditional custodians of the land on which we are meeting, and on which I am standing to do this presentation to you now. I pay my deep respect for the grace given me to be able to do this. This reoccurring acknowledgement towards this land's native population throughout all the sessions at the conference, who I have also overheard being described as tedious and time-consuming, might be a prime example of an attempt to slowly change mindsets. How we perceive and understand the truths of our action. I have to believe it's a start in the right direction. In Norway, we have treated our native population just as bad since forever. And I now feel embarrassed about it. I have been forced to reflect on this for the last days. I am thankful for that. And now the presentation. As parts of my presentation is a retelling of the patient Erlend's personal story, and in respect of who in this audience who have lived experience, I wish to give both a trigger and a trauma warning. If you say and hear something enough times, it becomes truth. You start questioning, like I have done now these days, or you stop questioning. We who are attending this global conference, who covers harm reduction in almost every possible form, we know that. Terms as junkies, criminals, lowlife, beggars, unresponsible, liars, infectious, dirty, promiscuous, crazy, and the list goes on and on and on, has been used in describing the disease of addiction and its consequences for the individual for such a long time that it has also become a truth. Other truths are total abstinence for everyone, punishment as a deterrent, and little or no freedom of choice in the help received or the medicine given. As a caregiver, I do have power. As caregivers, we have to acknowledge that power in our daily work. The reason I'm the one presenting today are because Erlend has important stuff to attend to. It is not because he has to spend all his waking hours getting money for the next hit, another dose of heroin, scared shitless, and then actually shitting himself because of abstinences. They are painful, and they are just hours away. He is commuting to the clinic twice a day to receive his medicine. He has gradually stopped injecting it intravenously, and he is considering a switch to the diamorphine tablets. And they are reportedly incredibly vile in taste. He's not at the clinic to get a rush or a high. He's not there to exploit the system or spend Norway's wealth. He wants to contribute. He wished to work and to pay his tax. He's taking baby steps towards an existence where no one looks at him sideways because he is begging on the streets. Those are his steps to take, and they have to be in his own pace. I acknowledge that. One day he will stand beside me, and I am stubborn, so that will happen, to tell the story. I am humbled to have been given his confidence in telling his story. Erlend was hospitalized during Christmas in 2021. Which button?
I used the mouse.
That. With blood clots in both lungs and infection counts over the roof. He got admitted and was basically in coma for 2 weeks or so. Here's the thing. He got admitted on his third attempt at the emergency room, mainly because a very experienced and wise colleague, nurse of mine, went there with him and refused to leave him alone, even 2 hours after his shift ended. Erlend tells me he would have left much earlier to secure the next hit if it wasn't for my colleague. He believes he would have died without help that Christmas, and that is a fact confirmed in the medical records from the hospital. Norway is widely recognized as one of the overall best countries to live in worldwide. As a nation, we are filthy rich of oil as well, in comparison to most of the world. I recognize my enormous privilege and incredible luck in happening to be born there. Sadly enough, Norway is also a record holder in overdose deaths per capita. We aren't that many, and we can't manage to keep our own people alive. After many years of debates, the Norwegian government decided of funding a 5-year-long project with heroin-assisted treatment. The first injections with medically prescribed diacetyl morphine was made in January 22. Surviving blood clots and infection, Erlend went directly for a meeting with his methadone prescriber, who asked if he would be interested in being a part of the project in Oslo. Erlend was in withdrawal and describes that his only thoughts was about how to end the meeting with the therapist as fast as possible to get downtown to score a bag of heroin. He agreed to go for a visit just to look at the newly opened clinic next door. He then had a short meeting with the medical director and a nurse, and he says that his main reason to agree, even in withdrawal, was that he finally felt he had met a caregiver, the prescriber of methadone, who actually listened to his views on his own treatment. A week later, in the beginning of February 22, he made his first injection with prescription heroin. The second injection, on the same day, he sneaked to inject in the groin. Not allowed. Thank God for the inexperienced staff at the time. Seen from the outside, with my background and experience, I am a harm reduction nurse at the Supervised Consumption Room in Oslo since 2009. I am good at what I do. I know what these people, I know who come and need my services. I have never encountered a more successful project. Never. It's a pilot project, and it's located in Oslo and Bergen. They started out with thinking 150 people, patients in each clinic. They have now reduced it to 40 due to capacity, due to understanding what needs. And the research project's resulting evaluation will be a report and will give a recommendation for the continuation. For many of the patients, it's already beyond doubt, and for many of us who works there, it is a treatment that significantly improves quality of life, and possibly one of the first to really acknowledge in Norway their addiction as a disease, an illness. Their transformation in such a short time, it's a year, are jaw-dropping to me. Erlend and many of the other patients there, the 41, has each started on individual journeys towards a different life. The fact that not all of the waking hours need to be spent on securing the next dose, and the money needed for said dose has added kilos to the body weights, and it has at least partially removed the ever-present stress of withdrawal. It has created space to dream, courage to reconnect, and time to reflect. I am privileged to really get to know the persons behind the addiction now. Research and numbers are important aspects for decision-making, but sharing the individual stories might possibly be the true stigma breaker. This is ours. Up, down. There. This is in September when we finalized the abstract. This was the first time we were at the coffee shop, together with my dear colleague down there. And he hadn't had a good, nice coffee in 5 years. I am so proud and humbled to be a part of his journey. Thank you.
All good? Yep, there we are. Thank you. Thank you very much, Tori. And it's a very good reminder that when we talk about advocacy and public involvement, there's the face-to-face part of all of that equation. And congratulations on the work you're doing. And we're so proud to be able to hear about it today. Our next speaker is Gloria, is the Regional Director of the Asia for the International Drug Policy Consortium, a global network of civil society organisations advocating for drug law reform and human rights. Gloria. Thank you.
Hi, everyone, and thank you very much to the previous speakers as well. Thank you. It's really awesome to hear about the work that you're doing, and I think maybe just to say a bit more about the perspective I'm speaking from. It's not as an academic, so I'm not presenting on a thorough study or anything. It's more, I guess, my experience advocating in the space that I do. So just to give you a bit more of a background, so IDPC is a network of civil society organisations around the world. I work out of Thailand. I'm Australian. I'm Chinese-Australian, and I've been in Thailand for the past decade and more, actually. So my work very much focuses on the regional level, and a lot of that work is around kind of trying to make spaces at regional level for dialogue and for civil society engagement. But a lot of that also is to support, in ways that we can, civil society working at local levels. So, what I'm going to talk about is a lot about our kind of emerging work on intersectional feminism. It's been for a few years now, but it's still an area that makes me incredibly nervous, constantly out of my comfort zone talking about this, and still trying to figure out ways to work on this. But I think it's important, and a lot of our colleagues are working in this space and also figuring out our way to and how this work kind of started very much from 2016, when there was a UN General Assembly special session on the world drug problem. And one of the wins was out of that kind of global commitment that came out of that was a focus on women and young people. And so we decided in Asia, the context, Southeast Asia, usually when you talk about it in terms of drug policy, people know it as having some of the most brutally punitive responses to drugs. So a lot of the kind of executions that still take place for drug offences are amongst countries in that region. It's consumption itself, not to mention possession, is a crime. And so-called health responses are incredibly punitive and sometimes even like worse than prison itself. And in countries like Singapore or parts of Indonesia, you would still have like whipping or caning, in addition to some form of compulsory treatment or incarceration. So it is really punitive. So one of the reasons why we thought of focusing on calling for a gender-sensitive approach was we thought that this was an opening. It's very difficult to find openings to talk about the possibility of changing approaches in those contexts. And I think in addition to having really tough drug policies, you also have very few spaces, and it's a shrinking space for civil society. There isn't much tolerance necessarily for civil society to speak up, least of all to speak up against kind of strongly entrenched government policies. So we thought if we kind of brought out the insights and supported, and including the voices of women who use drugs, that might provide some opening for people to be willing to consider an alternative way. And then along the way, there are movements of women who use drugs in the region, and some of the leaders are Rosma in Indonesia, in Malaysia is Yati, and they kept asking for ways in which they could be supported in their work. And at the same time, there was someone that came from, it's this really wonderful grant-making mechanism called Voice, and it's funded by the Netherlands, the Ministry of Foreign Affairs in the Netherlands. And I think it's been a really liberating space. So basically, out of this urging from Yati and Rosma and this funding opportunity from Voice, we managed to get a grant that covered a few countries in the region that was really just focused on the empowerment of women who use drugs, and including transgender women who use drugs and young people who use drugs or who have parents, family members who use drugs. It's not a HIV specific fund, so I think that kind of provided a lot more space. And Voice is really the kind of mechanism that really kind of pushed us to try to think about working in more intersectional ways. So thinking about other groups who also use drugs who we might not have worked with before. So we have two projects. So one is working specifically with Yati and Rosma and other leaders in some of the countries in the region. That's something that IDPC coordinates. And we've seen things come out of that. For example, like Women's Voice led by Rosma in Indonesia. They've become an independent entity, and they're led by a group of women, some who use drugs, but they come from really different backgrounds. Some were homeless, some are mothers or housewives, some are sex workers. And they've just started a shelter out of some funds that they're able to raise from UNAIDS, but it's still an ongoing project. And in the Philippines, they also just opened like a women's center as part of the community group of people who use drugs in a part of the Philippines, which is really awesome. So it's just showing how kind of precious that opportunity was from Voice. But another grant that we're part of is on intersectional feminism. And so I'm going to talk a little bit about that today. I think when we think of intersectionality, it's kind of like, what is it? It really something continually grappling with. In the end, I guess an easy, when the experts talk about it, it's a lens through which to look at something. It's an analytical, so it's been talked about as an analytical tool that can help us understand different forms of oppression, such as colonialism, imperialism, racism, homophobia, transphobia, xenophobia, sexism, patriarchy. And how those different systems come through, manifest themselves through interlocking structures of power, such as laws or policies or state institutions or mechanisms, religious institutions. So this comes out of the project I mentioned on intersectional feminism. This is a guidebook on intersectional advocacy that came out. And they're looking, these are all the kind of different kind of concepts that some of which I just mentioned. Why is it important to take an intersectional feminism approach? I guess the obvious answer, is that it helps us to recognize the different layers of discrimination and oppression that people face. And one of the leading pioneering thinkers on this, Kimberly Crenshaw, she says that intersectionality is a way of thinking about identity and its relationship to power. And I think for us, our challenge was to think, well, for women who use drugs, like, where do we fit on this kind of this interlocking web of power? And I think for me, this is maybe the biggest question at the moment. And we're also, I feel, struggling to find our space in this conversation about intersectional feminism. When we want to talk about drug issues and the impacts of drug policy and the oppression that's placed on women because of the punitive drug policies that are in place, how do we talk about that? What language do we use? And it's been really challenging, actually, in this project, working with these other feminist networks, because it's not a given, it's not accepted that women who use drugs or women otherwise impacted by drug policies have a space on the table to talk about women's rights. It's not a given at all. And actually, I was really shocked when we've had these big group meetings on Zoom where we try to raise the issue around even just a simple exercise talking about what are the different types of identities that are where people are marginalized. And one of us mentioned women who use drugs, and someone else said, no, we're not talking about prisons. And then it was not an accepted part of the conversation. So I think that's one of the barriers that we're facing. But we already have 2 minutes. Sorry, I thought I was being really brief. So part of the project, so these are the different networks that we work with in the region. Networks of Indigenous people, of sex workers, people working with refugee people, transgender people, and LGBTQ+ people, and women living with disabilities. It's amazing, despite the barriers are something that there is a given. As advocates, these are the barriers that you face in any conversation that you try to have about the need for drug policy reform. So it's the same kind of challenges that you face in this space. And I think here you have a space that's given to us where we are all supposed to feel safe in raising our issues. So in this project, it's around, there's different training workshops, there's different kind of tools to help us learn more about each other. And for me at the moment, is still learning about how little I know about what it's like to work in ways that are inclusive of women living with disabilities, for example, or of Indigenous women. And when we try to raise drug issues with them, like, for example, there's a lot of problems with people moving around in the region, refugees. If you think of Rohingya people, like, living in Cox's Bazar in Bangladesh, and a lot of the drug trade kind of flowing through there and the violence that comes with that, the Refugee Rights Network, they know that it's an issue, but they don't know how to talk about it. So it's something, this gives us a space to try to figure that out. And I think maybe just to end, the next thing to do is, as advocates, we're constantly trying to build our movement, trying to have more people speak out about the need for reform. So I think it's critical to keep doing that, and this is an important space for people who are already defending rights, women's rights, to also speak out on behalf of women who use drugs and women and transgender women impacted by these drug policies. We're finding our voice, what resonates. It's difficult because someone mentioned, maybe if I could have sent the other day, about how other movements have really kind of catchy things that just resonate with people straight away. But when it comes to our movement, it just seems so difficult. It seems like I have to speak in paragraphs to kind of try to get a message across, and even after that, it's still not come across. So we're still kind of figuring out how to talk about the issues we want to talk about in ways that resonate. And also trying to make a seat at the table, whether it's a formal table or a meeting, as Alison mentioned. Yeah, so thank you very much. Yeah.
Thank you very much. And again, I was struck by some words. The challenges that we have with engaging audiences new to harm reduction and drug policy reform. We can't necessarily assume that the people we're talking to have any basis intellectually or emotionally or personally in these issues. So we have to think through how we communicate. And I thank Gloria for her contribution today and the work that she's doing in the region. Our last speaker today, Augusto Nogueira, is based in Macau, and I think I should point out that he received a medal of merit from the Portuguese government for the work that he's done. He pioneered the needle syringes program in Macau. I think that's a pretty big achievement and deserves a clap in itself.
Okay. Again, good afternoon. Good afternoon to everyone. As he said, my name is Augusto Nogueira. I'm living in Macau, but I'm Portuguese, and I'm here representing the Vienna GOC Asia Working Group, together with my colleagues Penny Hill and Gloria. So, and before I start to speak, then I'd like to we'd like to acknowledge the Uru Jidiri people of the Kulin nations as the traditional custodians of this land and pay respect to elders past and present. And also, we'd like also to pay respect to our colleague Ramli Samad from the Pengasi, Malaysia. He was a member of our Asia Pacific Working Group, a colleague and friend that also contributed immensely to our common position that he passed away just a few weeks ago. So for those who don't know, Vienna GOC is an international NGO based in Vienna. Works as a vital link between NGOs and the Vienna-based agencies like the CND Commission on Narcotic Drugs, INCB, International Narcotics Control Bureau, UNODC, WHO, where we can directly engage them and discuss our concerns during the several meetings and high-profile meetings that there is during all the year. And also we promote the collaboration and support of the activities of the membership, of the members of the NGOs, communication with the UN agencies and member states. And we try to ensure a balanced representation of the NGOs with their different perspectives, ideologies, and groups involved during all the opportunities that we have with the relevant international agency, office, etc. Currently, Vienna GOC has 365 members from 100 countries across the world, being Europe the most representative zone, followed by Asia. This is our members in 2021. So, as a little bit as Gloria discussed before regarding the situation in Asia, so it was decided to create the Asian working group, Asia Pacific Working Group, and those the persons that initially start the group. So myself, Mr. Samir Kumar from India, Mr. Sana Ratori from Pakistan, and then our colleague Ramli Samad, Deneng Arti from Indonesia, and then Miss Marian Phillips from Australia, and Gloria Lai from IDBC Thailand, Miss Diana Vicent from the Faraway Foundation India, Asia, and also Miss Asia Ashraf from Pakistan. And the group was convened by Penny Hill, which is over there, and Sarah Pirker from Vienna GOC. So that's our initial group that we start to work in trying to form the Asia Pacific Working Group. The purpose was to strengthen the participation and engagement of the NGOs members of the Asia Pacific region, to involve more the members, improve the communication, the concerns, the situation in Asia regarding drugs, and these were the objectives that they are defined After some initial discussions, we decided those were our main objectives, which was to promote and explain the VNGO membership and expand the VNGOC membership in the region, because at the time only 56 NGOs were members. Help the VNGOC board in how to engage members of the region, also to understand better the issues in Asia, to bring the to bring the NGOs from the regions into the high-level debates, to share the real situation of what's happening in Asia, what needs to be changed, and what has, and also normally we speak a lot of the things that needs to be changed, of the bad situations, but we also would like to show what's is doing good in Asia as well. Improve the communication, the dialogue, creating webinars, etc., and select NGOs for them to represent at the high-level meetings, call for the speakers from the regions, for the VNGOC, for the intersessions at CND and other opportunities that we can, so they could raise their voice and they could show the work they have been doing in Asia and also express their concerns. And these are the relevant regions that we consider in Asia. Actually, we need NGOs from, if I pronounce well, Melanesia, Micronesia, Polynesia, and also from Central Asia and Transcaucasia at the VNGOC Asian Working Group. So we'd like to extend more members in our Asian Working Group from these regions. And since we created the VNGOC Asia Pacific Working Group, we nearly doubled the membership from the region. From initial in 2019, 56 members, and in 2022 there was 101 member. So at the end, we managed to increase the more members' participation from Asia. At the same time, also help the VNGOC to have more members. So we decided that we have to do something related to the region, to how we can, try to advocate the problems that are happening in Asia. So in February 2021, after some discussions of what we should do to call attention for the Asia Pacific region, mainly for the Asia of the situations that were happening, we started the discussions and we decided to create a common position. There was a side event was hosted with the participation of more than 70 NGOs, and all of them present ideas, centers that we should advocate, like health, death penalty, women. So there are all the NGOs. They start to send message and sentence about subjects that we could focus and we could see what we could discuss. In April of 2021, during the CND, a side event online was organized and led by the VNGOC to promote the discussion of the common position. And by July 2021, we present the first draft of the common position after collecting suggestions from all the NGOs that participate in the several meetings and webinars that we had. And then in December 2021, a third regional consultation was held, and the final draft was circulated in December 2021. And this common position afterwards was translated into several languages: Baha, Chinese, and many other languages. Finally, at the 65th CND Commission on Narcotic Drugs was the official presentation of the Asia Pacific Common Position as an NGO paper. The Asia Pacific Common Position on Drugs, it's not perfect. Of course, it's those ones that they support the prevention, they all say that is missing prevention. Those ones that support more harm reduction, they all say that maybe there is missing more harm reduction. Those ones that, I don't know. I think nothing in life is perfect, but the Asia situation, I mean, it requires a lot of attention. It's of course our common position is focused more in changes in measures of harm reduction that should be implemented in Asia. But we try to have at least a balanced common position and incorporate the perspectives and the guide work of a wide range of NGOs from across the Asia Pacific, and we hope we can help and shape and guide the civil society and government response over the coming years. So actually, we don't want this a common position just be a piece of paper that you put in your drawer of your secretary of your desk, but we want you take this common position and read it and see what you can work, what can be changed, what need to be changed, what can be improved, and take to your government or join with your colleagues from the other NGOs so you can work and try to work on your country on improving. 2 minutes, okay, almost finished. The common position objectives are basically very simple and clear. Capture the consensus among the civil society from Asia-Pacific region to reflect the necessity from placing human rights, health, and evidence at the center of all drug policies, and to guide and help us to pressure our governments of these necessities. Recognize how important we are on the discussion of the drug policies, but also very important to outline the success and the achievements of the civil society as also the challenge. So we also want to promote what has been doing good by the NGOs, by our colleagues in Asia, and try to be what is good to be the example in the other countries to show what's in the nearby region is happening good. In our discussion, we identify seven factors that should be addressed on the discussions, that they are the existing international commitments and treaties relating to drug policy, the inclusion of civil society, human rights, health, criminal justice response, development, cross-cutting issues, and 24 recommendations from the civil society were presented in the document. We're at the final document of the common position, which we hope, as I said before, which we hope that you can download there's the code over there. You can read, and hopefully you can sign as well and support us. Currently we have around 84 signatories and 57 from the Asia Pacific region, and I believe that we can increase much more. We can grow much more, and we understand that not everybody might agree with everything is written over there, but many of the things you might agree, so we can all support each other. Then last CND in the March 2023, we hosted a side event where we did a showcasing of the implementation of the Asia Pacific Common Position. So some NGOs are invited, also some of government they were invited, where they showcase how the common position was useful for them, and also things that they are suggestions for changes in the common position with the new suggestions and new ideas that we need to consider and in the next meetings that we will have. Now, a little bit of self-promotion from VNJOC. For those that are not members of VNJOC, you can go to the VNJOC website. So Sarah made a very good job. And you can download the membership form. And you must work in the field of narcotic drugs, need to be registered at the UNDESA, and you need to spend a little bit money. And the QR code is over there for the newsletter if you'd like to know more information. You will have access to the platform NGO Marketplace, where you can promote your work, share your work, and also see the work from the other colleagues, etc. And then I said before, there's the call for speakers at VNGO, often call NGOs to be speakers. This is the selection criteria that and all the steps that how they focus and they choose the relevant speakers. And that's it. And thank you very much.
Could I ask the speakers to come up? Thank you. I'd just like to ask Erlend, and I hope I pronounced that right. I think he's replaced Erlend. It's Tori, isn't it? Oh, Tori, I am sorry, I missed that. Look, I really appreciate your insights and some of the compassionate stories about the case study, if you like, of Alan, who received treatment. But would you have any more information on perhaps the details of the program, how doses are administered, how often? Just to help us sort of get an idea of the plan that we can perhaps implement in Australia and other jurisdictions.
Be patient with me. This is more scary, actually, to me, than standing up there. So you need to go there twice a day, and there are currently enrolled 47 patients. Since the start in January 22, we have had 59 patients through our doors. 2 have died for natural reasons, and a couple have gone on to long-term morphine tablets, which legislation in Norway just changed last year. So instead of choosing that, the dosage is decided, it's scaling up. They start on a very low dosage. We do accept that they have a side use of illegal drugs. Fill me in if there's something. And then we see that we experience that many want to go up and up and up in dosage, and they say, I can't get, it's not enough, it's not enough, it's not enough, and but the only further effect that we have in really high dosage is that we risk that they cramp, especially injecting intravenously. We do try to give time to get used to the idea of injecting in the muscularly instead, which most are reluctant to do that initially. And which is part of the hooked on the needle, these, and then gradually it just moves on to where they report that they don't feel the need for that rush anymore, actually.
Self-administer or do you administer?
They self-administer. Yes, I have helped one of the patients who broke his arm to inject in the shoulder, in the muscle, which is something I don't do at supervised consumption room, because then as a nurse, that is different. I don't know what I'm helping you inject, but at the heroin clinic, we do know what we help them to inject. No, but they do have. They can take release, long relief depot morphine. They get to take that home with them at night. We started with methadone and waiting for the new guidelines for treatment. Actually, we don't exclude. If they have a side have a side use, but we might give reduced doses if we perceive the patient to be influenced in some ways. And we see that also that goes down, the side use. We're very strict on times. So I sometimes meet patients at the supervised consumption room because they didn't manage to get there before 4 o'clock. Yeah.
Thank you very much, Dan. Up the back. Marianne?
Just a question for Alison. There's been a number of conversations, I think, about this, the diversity and embracing the diversity and being able to sit in discomfort and acknowledge disagreement. But at times it can feel almost unsafe and hard. And I just wondered if you had any comments about the balance between being comfortable with discomfort and embracing diversity versus actually lateral violence and conflict that's unhelpful.
Yes. I mean, you're absolutely right. It's very, very difficult to get the balance right. And I think it depends on the setting and it depends on the participant. And I mean, safety is crucial. And I mean, part of the ethnographic work was working with a team over a period of 13 months and seeing how the group had spent time together in positive ways, which made the spaces safer to facilitate the emergence of disagreement. So I think this is not something that you... yes, you need to be aware of safety and context and history and connection. And in fact, the second paper, Kari's very kindly tweeted the 2 papers on the hashtag Harm Reduction 23. The paper that's led by Laura McLaughlin talks about personal connections and relationships, and it's in that context that disagreement can occur. So it has to be relational. It can't just be outside of that sort of space. But it's tricky.
Sorry.
No.
I think there's a couple of here, one there and one here. There's three on this side and one at the back. So go first to the man here.
Thank you. My name is Alex Stevens from the University of Kent. My question is also for Alison about this issue of disagreement as a decolonising aspect of drug policy, which I think is really valuable. But you also talked about the labour that requires, the invisibility of that labour. I'm guessing the unpaid nature of that labour. And I was wondering if there's any gendered aspects, again, of that invisible unpaid labour.
Yes, I know the data, and it's definitely gendered, and it's the women who carry it, and it's the women with lived and living experience who carry a lot of it as well.
Okay, down here. And then across there and then up at the back.
First to Machteld. Yeah, close enough. I think that's really cool. I want to connect with you afterwards. But the question is for Tori. It might be a little Norwegian specific, but does the program exist under the current substitution program law and the same guidelines and strictness, or is it a separate program that's sort of exists independently?
As far as I know, the heroin-assisted treatment it's only Norway that it is placed under specialist hospital care. Normally it's privately funded organizations or community-based, so we do that, and there's pro and counters to that, but we are underneath the LAR, which is the
substitution treatment program.
Yep, thank you. Yes, so we operate under the same regulations. We do have some leeway. I think I can observe. Yeah.
Can a person that is using methadone currently request to switch to the heroin-assisted treatment?
Yes. At the moment we're full capacity, but if someone leaves for any reason, one of the inclusion criteria are actually that you have tried the other more traditional methods, and they haven't worked.
I have a question. Oh, sorry, Steph from Pennington Institute. I have a question regarding the ecstasy shop. Did you do any price modelling with the different formats of stores? And if so, how did it compare to the street price of MDMA?
No, but we did ask about pricing, of course. And we asked, for example, if people would be willing to pay more if that money would be used, for example, for environmental purposes or crime reduction or whatnot. And I think it's also because a young, quite progressive population, let's say, came to the shop, but people were really open to pay more for their pills when they know that it's environmental friendly. Crime they didn't care so much about. But environment, yes. And there was also quite a big lack of knowledge about the environmental waste that goes hand in hand with ecstasy production. And that's part of pricing is very relevant, I think. I think what the three different sets show different thresholds of how difficult it is to acquire your MDMA. And our market is so big and so easy to get pills, and it's so cheap that you cannot have too high of a threshold if you regulate this, because then the black market would just stay too big. So that is actually a really interesting, and pricing is one of the elements, but there's more where you decide how high is the threshold if you do this. And it can't be, in a context like the Netherlands, it can't be too high because then people won't come. So that's an interesting discussion, actually. Yeah.
Hi, another question for Tori. I just wondered whether the participants in the program have choices around the type of long-acting modality and whether it's mandated, in fact. Like if someone, for example, chose to, instead of taking the morphine tablets or another conventional OAT treatment, are they able still to participate in the program?
There's no obligation to take the take-home pills, medication at night, and some choose to come just once a day. Yep. Some choose to take the diaphene, the tablet, in the morning, and then having an injection in the afternoon. We have one patient who I would have never thought, honestly. He is now reducing his dosage. He wants to get off completely, very, very slowly, and on his own decision. So I think we at least we're trying to accommodate whatever they choose. Yeah, not always good at it. It's we are also learning at the moment. Yeah.
Thank you.
Any more questions? Perhaps I'll just ask Machteld, the Minister, has he positively responded to a regime of regulation as a result of your work and others?
Well, the minister is from one of the liberal parties, but the problem in the Netherlands is that he is part of a very conservative coalition, and that is a really big problem. So the discussion with him was really open, but he cannot carry this forward as a serious point. I mentioned that there's a state commission on MDMA, and he leads that, but there's a lot of pushback from conservative governments against that alone, and that's only talking about medical setting. And they are constantly saying, yeah, this is a trick to also start talking about, full regulation. So it's the conversation with him is open, and I know now that he loves Bruce Springsteen, so that's nice. In the club, he told me, but it's a long way to go. Yeah.
I think if there are no more questions.
I have a question.
Oh, hang on, we've got one, Heather.
Yeah, it's for me. Also, thanks everyone for the presentations. Also about the drug museum. Have you thought about how those different models might apply to other drugs like opioids and ketamine and cocaine?
Yeah, this is something really that we would like to dig deeper into. Ecstasy was a bit of a no-brainer because it's locally produced, and cocaine is quite an issue in our context as well because it's trafficked through our harbors. But cocaine is much more difficult to regulate because it has an international link. So we decided let's go first for MDMA, also because it's sort of more it has a slightly friendlier image than cocaine. But we would love to extend this to other drugs with all its complications and other discussions that you would also have to have there. Yeah.
Thank you. Thank you very much. Can I just thank the panel today? They all worked within the time frame, which is incredible. Thank you very much. And your contributions, I think,